Okay, so next we have investigations of axial spondyloarthritis. In investigations, we are going to, the diagnosis is aided by ultrasound or MRI of enthesis or by MRI of sacroiliac joint and spine. In this figure, this is the MRI. This is the MRI imaging appearance is sacroiliitis. Coronal MRI short T1 inversion recovery sequence showing bilateral sacroiliitis in axial spondyloarthritis. This is the sacroiliac joint. Bone marrow edema is present around both sacroiliac joint, which show irregularities due to erosions. Okay, so maybe these are the irregularities. And this is the spine. This is the iliac bone, maybe. Okay, there may include increased ESR-CRP, although these can be normal, anemia, and positive HLA-B27. Fecal calprotectin is a useful screening tool for associated inflammatory bowel disease. Okay, how do we manage it? Patient's education, NSAID use optimally, once daily or slow release taken at bedtime, and physical therapy are the key interventions at the onset for severe persistent peripheral musculoskeletal features of spondyloarthritis. Both sulfasalazine and methotrexate are reasonable therapy choices. These medications have no impact on spinal symptoms or disease progression in the patients who fail to respond adequately or who cannot tolerate NSAIDs. Progression to biological TNF inhibitors and should be considered. Okay. Anti-TNF therapy is effective for both axial and peripheral lesions of axial spondyloarthritis, but it is yet unclear whether anti-TNF therapy modifies the natural history of disease. What is the prognosis? With such a recent definition of disease, the markers of prognosis in the patients are not fully understood. It is clear that axial spondyloarthritis can remain mild or episodic in many patients for many years. HLA-B27 positivity, high CRP, and high functional incapacity are likely to be the markers of poor prognosis, if not markers of extension, ultimately to ankylosing spondylitis. So to summarize the management, we have the patients. We'll first of all educate the patient, give them NSAIDs and physical therapy. But if the disease is persistent or very severe, we'll give them sulfasalazine and methotrexate. And sulfasalazine and methotrexate are not promising drugs. They have not promised to act in stopping or preventing the complications of this disease. So if this particular set of drug fails, we'll have to give them TNF inhibitors or interleukin inhibitors. Interleukin 7A inhibitor can be given, which is secukinumab.